Hi, welcome to this week's installment of Stat Plus Conversations, a weekly video chat series exclusively for Stat Plus subscribers. Thanks for joining us. I'm Helen Branswell, Senior Writer on Infectious Diseases for Stat, and I'm excited to have the opportunity to talk today with Dr. Ashish Jha for the next 45 minutes or so. But first, let's run through a few housekeeping items. If you hover your mouse over the bottom of your screen, you should see a few icons. Please use the chat feature to chat amongst yourselves or to send a message directly to the STAT team if you're having any technical problems. But please be aware that I'm not going to be taking questions directly from the chat feature. If you want to submit a question that you'd like me to ask Ashish, please use the Q&A feature to type your question and I'll ask it live. There, you'll also be able to see the questions other attendees have asked and be able to upvote the questions you'd most like to have answered. So with that, I'd now like to welcome today's featured speaker, Dr. Ashish Jha, Director of the Harvard Global Health Institute. Thanks for joining us today, Ashish.
Hi, Helen. Thanks for having me on.
So, after months of really not great news, today we have some good news. Let's celebrate for a second. There's word out of the recovery trial in the United Kingdom that there is a drug that appears to have a beneficial effect that cuts deaths in severe cases of COVID-19. Let's talk about Dexamethasone for a second.
Yeah. No, this is exciting, and all of the excitement is based on what I've seen in a one-page press release. And so all the excitement has to sort of be curtailed by those limitations. But let's just sort of suspend disbelief, and then we should talk a little bit about what the complexity is of having everything in a press release. Steroids make a lot of sense for this disease. They clinically and sort of pathophysiologically make sense that they would be effective. And what we're seeing out of the recovery trial is potentially a pretty large effect for people who have severe illness. And severe really as people who are on oxygen or who are on a ventilator. And the number needed to treat, as again, we're sort of backtracking this based on the press release, is about 8 for people on a ventilator. That's a massive effect. For every 8 people that you give dexamethasone, you save 1 life. So that is pretty exciting if it holds up as being true, which I suspect it will, but don't know. That'll be great. And the only last thing I'll say, Helen, is, as opposed to remdesivir, which there are limited supplies and you have to, most people in the world can't get it, dexamethasone is, available in pharmacies and hospitals around the world. And so it is a drug that can be used pretty quickly, pretty effectively, pretty cheaply. And that is huge in terms of potentially saving lives.
Right. You mentioned getting the information from a press release. I mean, one of the things that is so different about this pandemic than any outbreak I can remember before is the way information is being disseminated between preprint servers and releases without studies attached. We really are sort of in new territory here, aren't we? It's kind of uncomfortable for scientists, is it not?
It's incredibly uncomfortable. Whenever I see papers in journals, what I do is, everybody reads papers differently. I start with tables and figures, and then I kind of make my way back to methods. I can do a quick scan of the methods just to make sure I have a sense of what they did, and then really try to understand it. With a press release, I literally have nothing. I have like the 2 lines of data that they decided to throw in, and no other information. And so the really fundamentally important questions, I'll explain why this one makes me a little more comfortable than most of the other press releases. Right. And just to say this, because they've got their protocols online, we've seen other stuff from the recovery trial. So it's not like I have no idea what database they're using or how they did this. But that all said, there's a lot of limitations here. And the last thing I'll say is I am not convinced that it's necessary, because the classic argument is that there's a trade-off between speed, it's a life-saving drug, we should get the word out, versus being thorough. It doesn't actually take that much time to take what they have and turn it into a preprint that they could put on a server, probably a couple of days. They could have done that. And they just chose not to, and investigators have chosen not to. And I think, that to me is unfortunate. And it'd be much, much better if they just put out some tables, figures, and a bit more detailed methodology. It would make us understand the data much better.
Right. Yes, one of our viewers is also not that thrilled by the notion of press release, announcements in terms of what works and what doesn't. Jeffrey Lazar says it's incredible that we're using press releases in lieu of actual science. This is shameful. Go back to medical history and find that Dex and other steroids that were once referred to as the surgeon's alpha blocker, when all we had to do to manage shock, also known as leave them dead. And well, anyway, he's making the point that you've made, and I think we agree. It's kind of uncharted territory a little bit. Let's move on from there. One of the things that I wanted to talk with you about is something that I've been noticing a ton, and I suspect you may as well. It almost feels like there's a second pandemic taking root right now, and that's a pandemic of denial. It feels like there is just this sense, at least in the United States, that this thing is over and we can move on, and let's get back to resuming our lives as they were before March. What's your thought about that?
Yeah. It's striking. I think, I think I said yesterday to somebody that we may be done with the pandemic, but the pandemic is not done with us. And, we are early, right? It's still, the other analogy I like to use, and Mike Osterholm I use this as well. I say we're in the third inning of a baseball game. I think he says second inning.
Yeah.
I'm like, come on, Mike, we're into third. But the bottom line is, we've got a long way to go. This is not the seventh inning stretch. And so, but it makes sense why so many Americans are feeling like we're done, and they're feeling a certain sense of apathy. First is that they were told that if we shut down and really kind of bend the curve, that we will be past the worst and everything will work out. Second, we had some data and some models, and we can talk about this if you want, which seem to imply that all of a sudden the virus would go away in June, July, August. I think there have been some real challenges in how some of the data have been modeled on this disease. And third is communication from our president, who clearly has moved on and is trying to act like this thing is all behind us. The problem is those are all fine, except none of them are reality. And the reality is that the virus is with us. The reality is that the first wave only hit a small number of places, and now it's coming to every other place and coming to a county or a city or a state near you.
Right.
And so if you don't live in one of these places that was hit initially, you're about to start experiencing it. And it's unfortunate because this is, again, I feel like we're gonna have to it's almost like Groundhog Day. We're gonna have to kind of keep reliving the same story over and over again.
Right. I actually think the terminology first wave, second wave is not particularly helpful. It's terminology that comes to us from the at least the 1918 Spanish flu, if not before, where it was quite clear that places had an early wave and then a fall wave or whatever. But we're just seeing like a succession of waves across the country with different places being hit at different times. Yep. And so to say that anybody is in or out of the first wave, I'm not sure we are. I mean, I don't think it's that distinct. I mean, right. I was looking before we talked today, and I think about 21 states have a rising incidence of disease, and about 20 have a falling incidence, and I guess the others are sort of plateaued. But it, the bottom line of that is there's a heck of a lot of disease left going on in the country, and people should not be assuming that their risk has disappeared, right?
Absolutely. The model, the best guess is we probably have about 100 to 110,000 people getting infected every day right now. And we're picking up about 20,000 of them on our tests. It's a lot of disease burden. And kind of the other models are that about 0.5, 0.6% of America is infected at any given moment these days. There's just a lot of folks with the virus. We are seeing kind of these different patterns across different states, but one of the things that I've tried, again, I agree with you about the wave thing not being super helpful, is that it can go, it doesn't take much, one set of policy changes to get you from your, oh, I'm getting out of my first wave, to all of a sudden into your second wave. And all of a sudden it just doesn't work anymore as an analogy. So it is helpful for people to have a visual, and there's something very nice about a wave that goes up and down. But not clear to me that this virus behaves that way, and that's a helpful analogy, even if it's something that people find useful.
One of our viewers asked the question about whether the US has the testing and tracing systems in place to address, a renewed surge of infections if indeed they hit in various points. What do you think about that? Again, it feels to me like the US is not one place. There isn't one system, or, there's a patchwork.
Yeah. One of the great pieces, there have been many great pieces written in this pandemic. One of them is by Ed Yong called The Patchwork Pandemic. And I just thought of that, Helen, as you were using that phrase. A couple of thoughts. I mean, first, at a high level, the short answer is no. The US does not have the kind of testing and tracing infrastructure that we need to manage the level of disease we have now. And assuming that we have more disease in the fall and winter because we're going to be spending more time indoors and we think the virus spreads more readily indoors, and we have no infrastructure right now to manage that level of disease. Now, one of the things that the president has done has basically said, let's really use federalism and let states manage this. Mm-hmm. And there is something attractive and logical about that, which is that, as some people say, rural Tennessee is different than Manhattan, which is different than Washington State. I completely agree. And you don't want just a single national response. It wouldn't work. But what you want actually is the classic way we've done public health, which is it's always been led by states, but with incredibly strong support, financial, intellectual, otherwise, from the federal government, usually the CDC. And what has happened is that second part of that package of state-led but federal support just hasn't been there. And so now you have 50 states all completely on their own, competing with each other, trying to build up a testing infrastructure. And let's just say it's not going well. And there is no sense that I or anyone else who's been kind of deeply involved in this has, that if we just leave it to all 50 states to compete with each other, that they're eventually all going to figure it out. A few states might, but most states won't.
Teresa Kaufman asks about whether or not, well, I think it probably stems from something you said earlier about, the president really being over this and wanting to move on. She's wondering if the country is going for sort of a washing over the population effect, which I think she means sort of moving towards herd immunity in the way that the Brits were going to do initially and Sweden has sort of approached. I guess she's wondering if we have a sort of unspoken policy of trying to drive towards herd immunity. Do you think that's the case?
No, I mean, there's a small minority of people who still sort of are out there saying this is no worse than the flu, but I don't think most serious people have that. Because if you just play it out and if you say, okay, we're going to kind of let herd immunity happen, couple of things. You'd have to have about 200 to 250 million Americans get infected. And even if you take a kind of a conservative infection fatality rate of 0.8%, even 0.5%.
Sure.
Right? And I think that's really on the low end of this. That's 1.5 million people dead. So remember that 100,000 dead right. New York Times cover, 15 of those. And that only was 1,000th of the, so you all know how, what a level of suffering that would be. And so I don't think that's what's going to happen. I think what is going to happen, well, there are one of two things that could happen. One is a muddling along. We're muddling along now, and we will continue muddling along. And in that muddle scenario, we hit 200,000 in September and 300,000 in December and 400,000 by March. And maybe 400 to 500,000, somewhere around there is when a vaccine becomes available and starts getting deployed. And maybe some of these therapies start really kicking in and then mortality rates come down a little bit. And we end up, let's say, kind of in that 400,000 range. That's a pretty likely scenario. And it's not herd immunity, it's sort of the muddle through the pandemic. I do think there's a more optimistic scenario where we could actually get our act together, but that most days when I think that, I mean, that's what I have to tell myself to keep going, but there is a level of optimism that requires.
Do you have a sense of, when we talked a few minutes ago about the fact that some states are going up, some states are coming down, do we know why that is? I mean, do we have a better sense of whether or not climate is playing a role? And it would seem that it might not be, because some of the southern states are the places that are on the rise right now. What is it? Is it better social distancing, better mask wearing, or something that maybe all of that and other things that we're not figuring into the equation?
Yeah, so the short answer is none of us know for sure, right? I don't think we have definitive evidence, but here's how I have understood it and thought about it as I've watched the data. So in terms of the issue of seasonality, climate, temperature, my best guess, and really this is based on all the data that's out there, data from Wuhan, data from other parts of China, what we saw in Europe and other places, and even in the US, and is that seasonality helps a little, that under warm weather, more sunny weather, actually more humid weather, there probably is a little bit of a decrement in the transmission of the virus, but not enough to buy you a virus-free summer. And we're already seeing that. And certainly people say, well, how helpful is heat? And I'm pointing out that the places with the biggest kind of rises right now are Arizona, Arkansas, Texas, the Carolinas, and Florida. These are not cool places in the middle of June. So whatever amount the heat buys you, it's not enough to make a big difference. The reason I suspect these places are doing as badly as they are is they opened up on the earlier side. Not every place. Georgia opened up pretty early and has not done as badly. And I think there was a lot of we're kind of over this. And so restaurants started getting full and a lot of indoor activity started happening, very little mask wearing. And I think it's that combination. Whereas if you look at a place like New York or even Massachusetts, Massachusetts is in phase 2, but we're not largely, a little bit, but not largely seeing a lot of gatherings. The restaurants are still being very careful. There's a much more of a careful approach to opening up here than what you saw, for instance, in Arizona, where they went to kind of phase 3 very, very quickly, when all the data suggested that they should not be doing that.
Right. Okay, so let's talk a bit about how things are playing out internationally. Some of the Asian countries seem to be continuing to suppress the virus pretty well. South and Central America are really on the rise. What are you seeing when you're looking ahead? Or even not ahead now?
I mean, one of the funny things about this pandemic has been that every couple of weeks, someone takes a look at the chart, kind of the global picture, the map, and then tries to make sense of it. And it raises all sorts of interesting things. For a little while, I was doing a lot of stuff on Indian television. People were asking, do Indians have natural immunity to this virus? I thought, why would Indians have natural immunity? And yes, there has been, and there's still some theoretical stuff around the BCG vaccine, but even beyond that. And the reason people gravitate towards those is they look at the initial data, and India didn't look so bad. And people pointed out that Iran got hit pretty hard, but Iraq didn't. Right. And so then there was a whole question of is there something special about Iraq? And what I try to point out to people is that when you're in this, at that point, the first or second inning of a baseball game, in a pretty virus that spreads in pretty idiosyncratic ways, that initially spreads through travel out of Wuhan. And so you're not going to get random cities that don't have a ton of travel hit as much. There's no doubt you're going to see a lot of variation. Right. But slowly over time, we're seeing a filling in and what you would expect. So Brazil has ignored the virus from a policy point of view. Certain states in Brazil have done a better job, but overall, nationally, President Bolsonaro has largely downplayed the virus. And now Brazil's number 2 in the world in terms of number of cases and adding a lot of cases every day. And Brazil's looking like a disaster from a virus control point of view. India went through a long lockdown. It's coming out and it's starting to have a lot of cases. And so I look at the global picture and I think we're going to have a whole bunch of new hotspots. across Latin America. Latin America, there's a bunch of places, Peru, Mexico, Chile, which actually has generally done a better job, but is struggling with a lot of cases. And across Asia, it's truly a global pandemic. And outside of a handful of countries that I think have done a good job, I'm really worried about what is going to happen in much of the world. And this doesn't even get into talking about sub-Saharan Africa, where, again, the cases so far have been small, but rising.
Right.
And I'm not, just like Indians are not immune, I don't think that people who live on the African continent are any more immune. We're all going to end up dealing with this.
So what are some of the implications of that? I mean, we're talking about India and Brazil. I mean, both of those nations are big vaccine producers, and India also makes lots of drugs. On the one hand, having a place to test the vaccines that are being developed would be useful, but on another, if these are going to be countries that are going to be looked to produce a lot of vaccine when it becomes available, are we going to have a problem there?
Yeah, it's a great question. One of the things that when China was really in the throes of it in January and February, there were all sorts of questions about China being a major medication manufacturer, and not always even manufacturing, but often providing the active ingredients that then went to India for the manufacturing. But either way, the idea that these are truly global supply chains, and there are a few countries that are really critical in those supply chains, is another reason why it's important to have a very global perspective on this pandemic. So one of the challenges, let me just make one side point and then I'll get to your main point. One of the side points is that in the US, it's been very tempting to look at this stuff in a very much a kind of, what does it mean for America? And I keep trying to remind folks that America is part of the world. And that's not just from a kind of, it's important to think about what the lives and health and well-being of people outside of the United States looks like, but even from a very selfish point of view, we are in a very globalized world where we need other countries to be functional. If India has, and now more directly to your question, if India has a devastatingly bad outbreak and workers who would work in these plants can't get there, you can't run these factories, you're going to have real problems with global medication supply chains and vaccine development and production. And so there are many reasons to make sure that India does not do very, very badly, but this just becomes one more of them. It has all sorts of interesting long-term implications for how we're going to, think about where we want our medicines produced. And I know that there's going to be a lot of folks who are going to say we want to do all this stuff internally, but during this pandemic, that's not an option. We're going to have to really look to places like India.
Okay, so the good news is we're getting a lot of questions from viewers, but that maybe is going to put you on the hot seat, but
I don't mind.
I can throw things at you. There is one question about whether or not there's any data on how dexamethasone works in subsets of patients, but I don't believe there was anything in that press release, right? I mean, we have to wait for a study to get that kind of an answer, right?
Yeah, and the before today, IDSA, the Infectious Disease Society of America, WHO, others were not recommending dexamethasone. There've been people, I'm sure, know that steroids for infectious diseases has a long history. We've tried them for lots of things. They generally don't tend to work so well, but there are occasional situations where they do. And they've been tried for various conditions that cause ARDS, and again, with variable success. I have to say, I'm sort of a bit surprised at the size of the effect that we're seeing from this therapy. Again, this is all based on 2 lines from a press release, so please, yeah. I reserve the right to change my views on these things, but we don't really understand the mechanism beyond it's an immunosuppressive, immunomodulator, blah, blah, blah. But we're going to need to really sort out how glucocorticoids are changing the disease course here.
Yeah, I'm surprised too. I've been racking my memory and trying to sort of spend some time in PubMed this morning, because I think during SARS-1, they were found not to be effective, in fact, harmful. So
higher viral loads and that, but some people still used it. Yes, sorry, I didn't mean to interrupt, Helen.
No, it's okay. That's fine. Okay, let's move on to a question from Nancy Reven. She asks, Seems like the only really good way to manage this pandemic is with robust contact tracing unless we have continued lockdowns. Are there other effective tools that might be helpful?
Yeah, I see this as that. So I, first of all, very much believe in testing and contact tracing and supportive isolation. Like, to me, that is a really critical tool. And then people say, well, what about when the outbreak gets too big? Doesn't it become untenable?
Mm-hmm.
And I don't see it that way. I don't see that as like a yes or no. I see us as having 3 or 4 tools, all of which are hard to implement, all of which have real costs, and they all work to some degree. And the more of those we can use. So social distancing is a good thing. The extreme version is, shelter in place. But hey, we don't want to do that, but we can get people back. We can get rid of the big events. It's still social distancing, and we can have some element of that we got to keep in place.
Right.
Wearing masks is a second tool. Unto itself, if we only wore masks and did nothing else, it wouldn't be very useful, but add that on to social distancing. And then throw in some, testing, tracing, supportive isolation. Even if you're not getting all the contacts, even if you're not really getting all the cases, it still helps bring the level of virus down. Put all of it together, and it's possible you can get your transmission levels low enough that you can live with a low level of disease in your community.
And still manage to maintain hospital services for non-COVID patients.
Exactly. And still have a semblance of economic activity that lets people get back, to their lives, not quite the same as before, but still. And hospitals can be functional, and we can take care of people. And just basically live with the disease until we're at a point where we have better therapeutics or a vaccine.
Okay. Someone named Lynn Matiso asks a question about asymptomatic people, how long they can be, well, she says remain asymptomatic, but I think what she's getting at there is how long they're infectious. There's a lot of confusion over this. And frankly, before I ask a question, I'm going to observe that a lot of the studies and a lot of the data that have come out have used a testing method called PCR, polymerase chain reaction, thanks, which doesn't look to see if you're infectious, just looks to see if you're emitting something that looks virus-like. And that doesn't tell us if people are infectious. I mean, everything I've read to date suggests that at least in cases that are mild to moderate, people stop being infectious around day 8 to 10. Is that your take on the data?
Yeah. So there's a lot we don't know about asymptomatic spread, but let me just be clear, because we don't want to do the confusion that our friends at WHO did. Was it a week ago? Feels like a month ago.
It was last week.
So much has happened. But where Maria Van Kerkhove basically was saying, she was trying to make a very kind of actually narrow point, and it became this big thing where, so we do think people who are without symptoms do spread the disease. And so here's kind of my totality of how I understand it. There's all these modeling studies that suggest that maybe 40 to 60% of infections come from people who are asymptomatic at the time that they spread it.
Right.
Just being very explicit about what I mean by that. Now, what we know is that some good chunk of those people will go on to develop symptoms later. And so then we turn around and call those people not asymptomatic, but pre-symptomatic. But for all intents and purposes, they didn't have symptoms at that time, so they were asymptomatic. And again, people differ on estimates. We think about 20%, maybe 16 to 20% of people who never develop symptoms. And we call them truly asymptomatic. And there are real questions about whether those people actually spread the virus and how much, and are they as infectious as people who do develop symptoms? We think they may not be as infectious, but we don't really know. And to your point, Helen, the reason why all of this stuff is confusing is ultimately the best data we have is things like, we look at people, the day they develop symptoms, we know because people have been swabbing them before they develop symptoms. We know they actually have a lot of virus in their throat, and so we think that they're spreading that virus and shedding virus before they become symptomatic. But how much of the spread is actually happening, we don't have great data. So long story short, small proportion of people are truly asymptomatic throughout the whole thing. A lot of people are pre-symptomatic, lots of asymptomatic spread. We don't really know how much. and we don't know how long for sure. But I think I agree with you. Probably about day 9, day 10, we think most people stop spreading the virus. They can be positive longer than that. And some of that is because they may have viral fragments that are going to be picked up by PCR. It's a confusing picture.
Yeah, it is. You mentioned the kerfuffle last week about the messaging from WHO. Let's talk a bit about health communications in this outbreak, which have been interesting, unique, ill-advised in some cases. Despite that misstep, the WHO has been holding sort of thrice weekly press conferences with translation available. So they're literally global press conferences. They're taking questions from journalists from all over the world, many of whom can speak in their own language. Not all, obviously, but many. Yep. By comparison, last Friday, the CDC had its first press briefing in more than 3 months, which I can't believe I'm saying that sentence. And, during that press briefing, they released literally no new information. They sidestepped questions about, the safety of mass gatherings, which made it seem pretty clear that they're walking a tightrope, trying to inform the public without annoying the White House so they don't get shut down again. Is this the way to conduct communications in a health crisis?
Yeah, so let's start with WHO, which, and again, it's very easy for me to be sitting here in Cambridge and criticizing, but I'll criticize a little armchair criticism. And I'll say, I think they've been good, not great. They've done a good job. They're pretty public. They're sharing information. But there have been a few times where they've kind of gone off on things that I don't understand. I do think some of their very lavish praise of China in the early days was unnecessary. They may have felt that it was helpful to them in terms of getting more access to what was going on in China. But I thought that some of that stuff was a little funny. I thought the mistake last week, and even their clarification was didn't really nail it. But this is but if you take a big step back, which is essentially what you're asking me to do and us to do, and look at the big picture here, yeah, WHO has not been perfect, but they've been pretty good and they've been pretty open. The CDC has been largely absent. And it's really important that somebody with scientific credibility be able to talk to the American people or to the world's population, in WHO's instance, about the state of the pandemic, what's going on, what do we know, what do we not know. And much of that in the US has come from the president, and then a little bit from Doctors Fauci and Birx. And it's hugely problematic that it's coming from the president. And this is not an anti-Donald Trump screed. It's when we had H1N1, we had Ebola, it wasn't President Obama who stood up every day and gave most of the stuff, because presidents are by nature political and they're polarizing, and people don't trust what they say because they're politicians. And it's really important to have somebody that most Americans trust, like Tony Fauci. And so if we replace the CDC stuff with a daily briefing from Tony Fauci, I'd be fine with that. But instead, we have either radio silence or we have a deeply politicized press conference from the White House with often not so scientific information. And it has created an incredible vacuum and a lot of confusion. And many of us, I probably spend, 6-8 hours a day doing media communication. And there's probably a dozen or more folks like me are trying to fill in the gaps. But at the end of the day, this is not it's fine, but it's not the right way to do it. And America would be much, much better off if we had, someone, a senior from the CDC doing this.
Somebody asked, and I've lost track of this question, but asked if, we're clear yet on the role kids are, here, Catherine McLaughlin, what is the role of children in the spread of disease? What are your thoughts on returning to school, especially with younger children who may not maintain social distancing even with the best efforts of schools? Right. Good luck with the social distancing thing. Yeah. What do you think about that one?
There's a lot of confusing science on this. So again, if you do those sort of swab studies of viral load in the nasopharynx or oropharynx, you see actually kids have plenty of virus when they're infected. And so not much compelling evidence using that kind of metric that kids are going to, not be able to spread. Now, there is some data that they have a lower attack rate, they're less likely to get infected. Some data that when they're infected, they spread it a little bit less. But here's my kind of big picture bottom line. If it's sort of a little bit like seasonality. Yeah, maybe there's some difference. Maybe there's a little bit of a benefit, but don't expect for that to bail you out. And in the same way, and we've seen this now with many places in the world, Israel, the best example recently, they opened up and I don't know, they were open for about 2 weeks and they had to shut down a large number of schools across the country because they had large outbreaks. And so I am very worried about schools this fall and winter. And not because I'm actually one of the few public health people I know who thinks we can open schools. Of course, I'm one of the 330 million Americans who believe we should open schools.
Right.
Everybody thinks we need to try to figure it out. I actually think we can, but I think the people who think they can are way underestimating the risk, are way underestimating how hard it's going to be. And yeah, social distancing is going to be part of it. You're going to have a really aggressive surveillance system, and you're going to have low levels of virus in the community. Because I say this to workplaces and I say it to schools, you can have the best program in the world for your institution. But if you're in a community with a large disease outbreak, good luck keeping it out of your institution, out of your workplace. So that's really the strategy. If we want schools open in Massachusetts, got to keep the virus levels low in Massachusetts.
Yeah, I mean, among other things, it's not, schools require teachers as well as students, and
Yes.
If the kids don't get terribly sick, but their teachers do, there's another problem.
Yeah, that's why I've been like the idea of, well, it doesn't matter if the kids get infected is the part I've been ignoring, because I think, of course, it matters, partly because they're going to go home and infect their parents or grandparents, the teachers, the staff. So the question is, how do you keep outbreaks low in schools? Not necessarily because you don't want kids infected, we probably don't, but because of all the spillovers it's going to have on everybody else.
Okay, I'm going to ask you, is it okay with you if we go a little bit longer? We got lots of questions and
Okay.
we can, oh, good. So I'm going to pick up on one of mine. There's a huge race right now trying to develop vaccines. Everybody thinks that the way out of this eventually is to get to the point where enough people are protected that this virus can't collapse our healthcare systems. There's a lot of concern, and it sort of bubbled to the surface last week in an op-ed that was in the Times, written by Paul Offit, who's a very renowned vaccine researcher, and Zeke Emanuel, a prominent medical ethicist who worked for a while in the Obama administration, that the current administration will try to race vaccines into use before the election to try to, have an October surprise type situation where, we're using effectively vaccines that have been very lightly tested. Is that a legitimate concern, do you think?
So without getting overly political, I think there's always a fear that politicians will try to manipulate science, especially in super high stake things like the presidential election. So would I be shocked if the Trump administration tried to do something like that? No, I wouldn't. Do I think it's a good idea? No, I think it's a really bad idea, but that's not that surprising. I think the bigger issue is going to be whether anyone's going to buy it as a story. And the issue is going to be that are people, so what could they do? I could imagine that if you wanted to do this, instead of having very clear data that the virus is providing immunity, you could rush things based on showing that it's generating antibodies and that these are in the laboratory neutralizing and maybe useful. And I think that the key is going to be, and obviously by October, we're not going to have enough safety data, I think, in large enough numbers of people to feel really comfortable. And so I think that's going to be really important for the scientific community to stand up and basically push back on this and say, this is not acceptable. The other part that I'm worried about is what the FDA is going to do. because ultimately the FDA would have to issue an emergency use authorization. And the FDA's a stellar agency that has always, not always, but has been really driven by science forever. But the last few months, the performance of the agency has suffered. And while I have a lot of respect for the scientists there, am I confident that they would let science drive their decision-making over political pressure? I am not. And the hydroxychloroquine initial move to do the emergency use authorization, I think I think for a lot of people was a sense that there's no way that there was enough evidence to allow for that. And it was clearly political pressure from the White House. And I think people are going to worry about that. So a lot of complexity, but I think we have to hold firm on what are the metrics that we care about before any of us declare that it's a vaccine that we would give our children or our elderly parents or ourselves. Mm-hmm. And it's hard for me to see how we get there by October.
Right. One of the things that comes to mind when I was listening to your answer was hydroxychloroquine is a drug that's already licensed. You know, there are decades of data on safety, not necessarily in this context, but, you know, I think it's a different thing when you're talking about a vaccine that you're giving to healthy people in large numbers. I mean, don't you kind of feel like the bar would be different, set at a different level?
Absolutely should be, and absolutely should be. I guess the question is, am I confident that the FDA will not buckle to what might be intense political pressure, mm-hmm. right? Probably the most intense political pressure they'll ever feel. Am I confident that the FDA won't buckle to that pressure? I'm not so confident of anything these days when it comes to kind of political stuff like this. So that's the part I worry about. But there is no doubt that the bar has got to be much, much higher because you're literally intervening on people who are totally healthy, giving them something that no one has ever, that humans haven't experienced before, and hoping that it doesn't end up harming them. You know, I believe vaccines are incredibly safe and generally effective, but that's because they go through years and years of testing and all the stuff. If we short circuit all of that, it has a possibility of really harming everybody's confidence in vaccines.
Right. And of course, even, you know, the vaccines that are licensed, many of them save lots of lives, but in small numbers cause unusual side effects. And, you know, when you are talking about giving vaccines to billions of people, something that occurs at a 1 in a million rate or 1 in 10 million rates is actually going to be noticeable and potentially eroding of the confidence of the population.
Absolutely.
Yeah. So there are lots of companies working on vaccines. Initially, there weren't enough, and now everybody almost, except for GSK, is producing all the major vaccine manufacturers are producing a vaccine. How do you see the rollout of vaccines going? I mean, is it going to be a free-for-all? Is it going to be, what do you think?
So it is hard to predict. I suspect that we will have maybe 3 to 5 vaccines that by the end of the year, calendar year, are looking really, really promising, that we have good data. Mm-hmm. A bunch of them probably have already gone into production and are producing a lot of doses. My guess, and I honestly don't know for sure at all, but my guess is that China might get there first in terms of having a vaccine that has been shown to be both safe and effective.
Right.
The challenge with the Chinese vaccine, their production challenges, is an old method. There are issues around immunity. The one issue that has been brought up, I think you and I have talked about this, Helen, in the past, is the issue of there aren't a lot of cases in China. Right. So how do you test it? But there are a lot of cases in Brazil, and so they're doing that. So I can imagine. So first of all, that'll be very interesting from a geopolitical point of view, is what happens if China has a vaccine before everybody else. But my guess is there'll be several more that will be soon to follow. And it will be a free-for-all. One of the key things we want to do is sort out data, like are there some that are more effective at protecting older people than others? But all of that takes time and really careful scientific work. And I worry that the fog of the politics and the craziness will make that hard to do. And we'll really have to try to stick to our guns on making sure that data is driving those decisions.
Right. And within the United States, I mean, you think we're ready to roll out vaccines at, mass numbers of people? I mean, they want to be able to vaccinate 300 million people early in 2021. That's a massive project.
It's a massive project. And this is, this is obviously a large chunk of what Operation Warp Speed is thinking about and the folks running that. I think there are parts of it that we can do. When I talk to folks in the vaccine manufacturing sector, they tell me that we are underestimating the complexity of even making 100 million doses. I mean, I'm sure I am, but even the people really working hard on it are very worried about whether you could make 100 million doses reliably and safely by January or February. Because this is a new vaccine. This is not like what we do with the influenza vaccine every year.
Right.
So it is a very different thing. And then there's a whole issue of then can you envision getting it out to people and putting it into the arms of 100 million or 200 million people? And then there are really interesting and important issues about, what kind of protection is it going to give us? And I think you've written really nicely about this, Helen. But, the idea that like you get the vaccine and then you're done for life and you never get almost surely not, right? Like that's, so it might be that people don't get severe disease, but they'll still have mild coronavirus, kind of, cold-like things. But that'll mean that older people will need to all get vaccinated, because if they're the small number that don't get vaccinated and then it's circulating among younger people and they pick it up, they could get really sick and die. So there's a lot of complexity here.
Mm-hmm.
This is not simply we need a single phase 3 trial and once it's done, we're good to go and the pandemic is over. Many, many steps between that and bringing this thing to and I wouldn't even say bringing it to a close, but bringing it to a point where it's not so acutely urgent in our lives.
Right. I mean, it's finding a way to live with this virus, probably, right?
Yeah.
That sort of segues nicely into a question from somebody named Bob C., who asked about, will the virus mutate like influenza so that people will need annual vaccinations? I mean, I think the analogy to influenza is useful in the way that you just sort of alluded to, that it may not be a slam dunk vaccine. It may not be a one and done type of vaccine or two and done, but I don't think we think that this is going to mutate with the same kind of speed as influenza, do we?
No, I agree with that. So my expectation, as I'm both reading the literature, talking to virologists and really thinking about this, is we may very well need an annual vaccine, but it might be the same vaccine. It's just that it may be that you may not get durable protection. And so every 12 months you need to get a booster or something. That's fine. But I don't think it's an issue of there's enough mutation that you need to develop a new vaccine every year. To me, it's much more about durability of protection than it is about mutations that require a different vaccine combination.
Right. You had mentioned earlier, this is a vaccine question, but a bit of a different one. You'd mentioned that India might, initially when it seemed like India didn't have a lot of cases, people were wondering if it had something to do with the use of BCG there. For people who don't know what that is a tuberculosis vaccine that is used in some countries in the world, not in the United States. Can you talk a little bit about that and, whether or not that theory that was quite prominent a few months ago seems to be playing out at all?
Yeah. So a lot of people in places like India got a BCG vaccine. I got a BCG vaccine when I was a kid growing up in India. And it's not particularly effective in adults. And by the time, it's not like it provides lifelong protection at all. There is some evidence that the BCG vaccine is immunomodulatory against some respiratory viruses. Mm-hmm. So it's not a crazy idea that having BCG vaccines may protect you. Maybe it doesn't protect you, but maybe it prevents really severe disease. If that turned out to be the case for coronavirus, I'm just being honest, being very clear. So if that turns out to be the case, I don't think any of us would be surprised. But has been an idea that's been thrown around a lot. So the evidence here is pretty weak, to say the least. It's a lot of ecological data, India doesn't have very many cases and has a lot of people with BCG vaccine. Well, there are a lot of other things that make India different than Italy, not just the BCG vaccine.
Right.
Second is there's some increasing data, evidence from places like Israel where they've like put in a BCG vaccine policy, and then like everybody used to get it before and then didn't after, and they don't find any protective effect. We now have a bunch of clinical trials going on, at least 3 or 4 that I'm aware of giving people BCG vaccines and seeing if it's useful.
Right.
I'll be honest with you. My guess is it won't be, but I could imagine that it may not protect you from getting infected, but it might protect you from severe disease, and that would be great, right? That would be great. But I'm not holding my breath on this, and we'll have to see if the science bears out any benefit at all.
Right. One of the things I would say about that is that, it's one thing sort of trying to measure whether having been vaccinated with it in childhood gives you protection years and years later, or versus getting it now and having some off-target benefit in the near term. I mean, I know one of the groups at Harvard is vaccinating healthcare workers to see if
Megan Murray's group.
Yeah, and other people, Bob Gallo, among them, are advocating the use of live polio vaccine for the same reason that sometimes live vaccines just effectively kick up the immune system, so that you might get some sort of a short-term boost that might help healthcare workers. Potential. And part of it is there's so much of this virus and the immunologic response to the virus that we don't understand and know. And there are a whole host of theories around this stuff that I think we just have to let the science bear itself out. And by the way, just one other kind of related, but not quite, even the hydroxychloroquine study, which I shouldn't say study, the hydroxychloroquine story, which, with the FDA's recent kind of yanking of the emergency use stuff, feels like, okay, that story has come to an end. It hasn't come to an end. There's a bunch of clinical trials. And there are areas where we don't know, and there's still a chance that it could end up playing out. So there's so many theories about all of this stuff, and my general feeling is there are a couple places where the science is such that I'm pretty optimistic. Antibody therapy, for instance. I actually think that that's going to end up being a potentially really useful, thing for people who are ill. But these others, I don't know. I'm skeptical, and I have to say, dexamethasone caught me a bit off guard because there's such a long history of steroids not necessarily being all that useful for these kinds of things. So that's why we have to do the science. Okay, quick lightning round because we're going to run out of time. One of our viewers wanted to know if these results with dexamethasone suggest that other steroids might be useful too, or do you have to test everyone individually?
Well, there are 2 parts of this. How about other glucocorticoids? That's one possibility, like prednisone and all those. And I would think that those others would be just as effective, or also effective, I should say, but we probably have to do some amount of work to sort that out. Dexamethasone particularly is a little bit different than some of the other glucocorticoids. And now I'm getting a little bit beyond my expertise on the different glucocorticoids. There's a different issue also, which is, how about other immunomodulators and anti-TNF alpha and all those others? There are a couple of studies on anti-IL-1 and IL-6 drugs. I think they're all in play, and there's a lot of potential interesting opportunities. We just have to sort out whether any of them really offer a lot of benefit, and whether they offer more benefit than Dex, because dexamethasone is cheap and easy, and you'd have to really show a benefit above and beyond what dexamethasone has done, which has now raised the bar. So let's say, if we were doing this yesterday versus today, the immunomodulators have a higher bar to clear now, I think.
Right. Okay, so last question. We're getting a bunch of questions about face masks, cloth masks, shields. What's your take on what the data that's been accumulated so far is? Because to be frank, it seems now to be accepted wisdom that yes, we should all be wearing cloth masks, but at the start of this thing, there was no data available about what benefit there would be from that.
Yeah. I think the benefit, the data on this is I sort of see it as accumulating, and there hasn't been like a single great study that kind of nailed it. It's just sort of study after study. I see it as kind of a steady drumbeat that suggests more or less that more face covering, the better. And I certainly at this point, I am of the belief that we have enough evidence that that's what we should do. There have been a couple of studies that suggest maybe they weren't useful, but a couple of them actually ended up getting withdrawn because they had methodologic problems. So it's really the totality of the evidence, not any single study that to me really proves that face coverings are going to end up being useful. There is a big debate about just, regular cloth masks. How about N95s? I think many of us feel that, in the ideal world, if you had the ability to have lots of N95s, not just for hospitals, that they might be better, especially if you're in more high-risk situations, if you're working in an office and you're indoors. But that would require a federal government that uses its powers to really drive up production of these things. And I'm worried that while we may be in better shape than we were in March or April, we're not nowhere near in good enough shape to get us through the fall and winter that's going to hit us sooner than we think.
Okay, so unfortunately, I'm going to have to wrap it up there. We still had a lot of questions. Thanks so much, Ashish, for joining me today, and to our audience out there for tuning in and submitting all these great questions. Just so you know, we'll be hosting STAT Conversations on Tuesdays at around 1 p.m. ET every week. Please be sure to sign up for next week's chat, which features the hosts of STAT's Read Out Loud podcast, Adam Feuerstein, Damien Garde, and Rebecca Robbins. They'll be taking your burning biotech questions live over Zoom. We hope you'll join us then. Thanks very much, everybody, and thanks again, Ashish.
My pleasure. Thanks, Helen. Be well.
You too.